It's River to River from IPR News. I'm Ben Kiefer. For years, the story around deaths of despair has been one of the more alarming trends in our country's public health. Deaths of despair. This is an umbrella term for suicide, drug overdoses, alcohol-related deaths. The phrase deaths of despair was coined by economists Ann Case and Angus Deaton back in 2015. Their research highlighted a startling and unusual trend. After decades of steady decline, life expectancy for certain segments of the American population, specifically middle-aged, non-Hispanic, white Americans without a college degree, had begun to reverse. A new report shows these types of deaths are actually falling nationally. But that's not the story everywhere. In several Midwestern states, including here in Iowa, the numbers are still climbing. Later this hour, we'll dig into why that is. I'll be joined by Daniel Wheaton of the Midwest Newsroom and Dr. Alison Lynch of the University of Iowa Healthcare. They'll help us understand what's driving Iowa's numbers in the opposite direction to the rest of the country. Well, let's start in northwest Iowa, where that trend isn't an abstraction. Lauren Williams grew up in the town of Marcus in the northwest corner of the state, nestled within Cherokee County. About 3 years ago, Lauren lost her brother, Michael, to suicide. She's a nurse, and since then, she's also become a host of her own podcast about mental health. Yesterday, I spoke with Lauren together with Kayla Mayer. Kayla is Public Health Manager for Cherokee County, also the leader of that county's Suicide Prevention Coalition. Lauren, Kayla, thank you for joining us.
Thanks for having us.
Yeah, thanks.
Lauren, I'm so sorry for the loss of your brother, and thank you so much for raising awareness by being on our program to talk about this loss and to raise awareness.
Thanks, Ben. I always appreciate everyone's condolences, and I always love the opportunity to talk about Michael, even if it is in a sense.
Mm-hmm. Start off by telling us about your brother, Lauren. Who was he? Growing up together on a farm in Marcus, right?
Yes, he was always the funniest member of our family and typically the funniest member in the room also. And he was a very supportive and devoted brother. He loved to talk with his friends and enjoyed sports, enjoyed watching the Green Bay Packers, whatever season they were having. And he was there for you. One noticeable thing about Michael is that he rarely was on his phone when you were around him. He took that time as precious time, and it was devoted time, and it was actually unique for society's norms. And he graduated from Iowa State University with his business degree, moved to a big city, and then after COVID hit, that's where he found himself a little bit more isolated, and the isolation pandemic effects set in. His anxiety was starting to increase, and he had battled with anxiety before, used antidepressant to aid in that treatment. But there was a moment where it became too much, and despite getting him to the hospital, he took his own life several days after being released from a psychiatric unit. And it was just the greatest devastation that our family's ever faced.
I cannot imagine. At what age did your brother take his life?
He was 28 years old, very young, and he was also very mature and wise above his age. So that's what it makes it seem like he wasn't actually so young. He was kind of an old soul, but he definitely had the energy of a college kid all the time because he loved to be social, loved to be around friends, but sometimes it was actually a double-edged sword because when he started to see how he could be in those public settings without alcohol, then that's when it caused him to have a lot more anxiety, and he was having to mask a lot more of those symptoms. And with his journey of going through AA, it wasn't anything really out of the norm for him. It was great that he was doing it. He was overall, his health was better. But it was just something I believe that the alcohol masked for a lot more years that we didn't see. And so it was a longer time frame that he was actually struggling than what we could see or what doctors could see on paper.
Lauren, I understand your brother Michael was diagnosed with general anxiety and depressive disorder in his late teens. So take us back a little bit farther in his life to his late teens, or perhaps even earlier, when you and perhaps other family members first noticed he was struggling. How did that unfold in hindsight?
Well, I am about 8 years older than Michael, and my other sister is the other sibling, Megan, is 4 years younger than me. So I was out of the house in college, and I know that there are some family dynamics where you take a um, very personal, private approach to things. I think it can kind of go into two categories. You have this personal, private approach. You're not going to tell anyone, or you do know the resources that are available. Given the fact that my mom had struggled with her own mental illness, I had struggled with anxiety and depression also. Our family wasn't a stranger to mental health resources. So I think that that's what kind of caught this by surprise is, yeah, Michael would always be making the jokes, trying to cover up his anxiety. And we would always just, that was what we loved about his character, what we loved about his personality. But yet it was almost to his default, because when he wasn't able to be honest and genuine, and come to terms with the reality of the situation of how bad those thoughts had gotten, then that's when it was too late.
I want to pivot over to you for a moment, Kayla Mayer, Public Health Manager for Cherokee County and the leader of your county's Suicide Prevention Coalition. Give us the bigger picture before we continue listening to Lauren's story of losing her brother, Michael, to suicide. What do the numbers show about suicide in your county in Northwest Iowa right now in Cherokee County?
So I would say the numbers show that there is a concerning rate of suicides in our community. It is potentially going down a very, very little bit, but every time there's progress, there are definitely setbacks. And so yeah, I think the data is showing that the suicide rates are concerning in our community, and we definitely have a big concern to address.
I understand it's hard to pin down the data county by county in some cases. Can you tell us a little bit about how your county, Cherokee County, compares to the rest of the state?
Yeah, it is really difficult to compare because data sets change, data measurements change. There isn't really a good system in place across any of the data reporting measures that I have found that will be able to compare county to county. But previous measures that we were comparing against is that we were 1.5 times above the state average for suicide rates in our community.
Mm-hmm. And what tends to be underneath these numbers? What role do things like adverse child experiences or single-parent households or substance use play? Kayla.
Well, as far as data goes, those are pinpoints that we certainly have really good data around. One of the things that we know is a factor in suicide rates is the ACEs, so adverse childhood events. What are things that are the ACEs? They are emotional abuse, physical abuse, divorce, substance abuse, suicide attempt by a parent, things like that. And so when we look at that data, we do know that in Cherokee County specifically, 1 in 4 adults are struggling with drinking. And that's pretty significant. 1 in 4 adults struggling with drinking. And I'm not sure it's always seen as a challenge. That is a challenge in itself. And then the other data points that we know about related to adverse childhood events is within the surrounding counties, probably about a 5-county measure, we have the highest rate of single parent households, which is 10% above the average of our surrounding counties. And so that is a pretty significant challenge, I think, in our community, and addressing that is certainly a challenge as well, but it does play into those pieces.
Mm-hmm. And briefly, before we take a break, Kayla, we heard in Michael's story that alcohol was a factor, both as a coping mechanism and as a risk factor. And that rings true of a lot of stories that you come across, I'm sure.
Yeah, I think it is definitely a just ringing factor in a lot of these cases. And I think that is something that certainly could and should be addressed. But we really have to go back to how are we thinking of alcoholism? Are we thinking of alcoholism as the person who is drinking every night before bed? Or are we thinking of it as it is the coping mechanism and we're not realizing it? And so that's the point where it becomes a problem.
We have to take a short break. We'll be back with more of my conversation with Kayla Mayer, Public Health Manager for Cherokee County. Also, Lauren Williams with us from Cherokee County. Lauren lost her brother, Michael, to suicide 3 years ago. We'll be back in just a moment with more River to River from IPR News. And we're back with more River to River from IPR News. I'm Ben Kiefer, this hour focusing on deaths of despair, and one of the more alarming trends in our country's public health recently, an umbrella term, deaths of despair for suicide, drug overdoses, alcohol-related deaths. And a new report shows these type of deaths are actually falling nationally, but not everywhere. In several Midwestern states, including Iowa, numbers still climbing. So this hour, we're starting off with a recent conversation with Laura Williams, from Cherokee County in northwest Iowa. Lauren lost her brother Michael to suicide. Also in this conversation, Kayla Mayer, Public Health Manager for Cherokee County and leader of the county's Suicide Prevention Coalition. Lauren, before the break, we talked about alcoholism. You talked about your brother using alcohol as a coping mechanism. Tell us a little bit more about that, if you feel comfortable. He moved back to Marcus in Cherokee County during the pandemic after a life in Denver, I believe, fell apart. Talk about that transition, how it affected him, because he got sober about a year before he died. Tell us, did that change things for him?
Yes, I believe so. A little bit of just in general, if you're using alcohol, it's a matter of not necessarily what the substance is, but the matter of the time frame that you want to escape. Any moment in your life, any situation where you want to escape a little bit, and you're not working through the tough stuff. And so when he decided to become sober, he actually had moved to Omaha, and so he was living in Omaha near me, and we got to hang out a lot, and I would take him to AA meetings, and he was really just loving the camaraderie and the partnership that he had with other AA members. But I think deep down inside, Michael was really struggling with a lot of other things from his past, and he really wanted to try and perfect it, and to just, he was, I think by nature, struggling with that comparison theory, where he's just comparing himself to everyone that's his same age. He also had a 10-year reunion that was coming up, that was close to the time of his death, and I think that all of those things went together. The biggest aspect of suicide to get across to someone that is, a family member that survived a suicide loss, that they need to understand that it's never just one aspect of someone's life that causes them to take their own life. It's usually a mound of different obstacles and life situations. Michael was in the mode of trying to create a new career path for himself. He was doing a lot. He was working on a lot of this self-reflection, this journey without alcohol, and then also a journey in his career path, so that he wouldn't be so isolated in the workplace, because his workplace was his apartment, and we all know how well that can take effect on your mental health when you're not socializing. So that is what I want to get across regarding Michael, is that he was working and striving very hard to get somewhere, and it just didn't ever seem to cut it. And that's kind of when the bubble burst.
Yeah, and talk
Yeah.
more about the 10-year reunion, high school reunion that you mentioned. That seems to be pivotal here. And you said he was having trouble dealing with his past. I understand there was a drive home and a conversation you had with him that stands out.
Yeah, it was actually when we were returning back from the reunion. Michael did great. He got to reconnect with his school age friends, had a good time, was proudly sober, and but it just felt like a lot of pressure, um, and a lot of persona to uphold, because he was doing all of that without alcohol, and he didn't have the stability in his career. And so he would just kind of felt just off kilter. And when we traveled on the way back, he just broke down in tears. And that's when I knew that, something was really, really, something devastating was happening to my brother. And it's hard to see, and we need to be more okay with having men cry and being okay with it, because I think he wanted to cry for a long, long time, and it just finally came out. And like I said, throughout this timeline, we notice that there is a masking, there's an escaping, there's a pattern of trying to get away, and all of those were covering up his true symptoms of mental illness.
Mm-hmm. Kayla Mayer, talk a little bit about the Prevention Coalition. The coalition started in 2019. What changed to make county leaders say, we need to do something different?
Yes, in 2019, there was an unfortunate string of multiple suicides in a row. And so at that time, the Cherokee County Board of Health said, someone needs to do something about this. And so that is when the Suicide Prevention Coalition started. And since then, I think we have grown in momentum, grown in passion for making a difference in our community, and really have striven to be the change that people are looking for in the best ways that we know how. I don't think nobody has all of the answers on this, and it is challenging because, just like Lauren said, it's not one thing that is causing the problem. It's usually the final straw that breaks the camel back. So I think that makes it a really challenging issue to deal with as far as tactics, but that's where we're at in our county.
Yeah. Lauren, you work in the healthcare field. In fact, you work in an adolescent psych unit. Tell us about Michael those final days. He was held, I understand, on a voluntary hold, then discharged. He took his own life less than 72 hours later. What went wrong with the process in hindsight, the discharge process, that should have been different, perhaps?
Yeah, so it is hard working in healthcare to have your loved one be on the receiving end of that and to see the process and where there are gaps in the process. So I believe that the providers did the best that they could with the information that they were given. No one wants to be on a psych unit, and if there can be a simple medication tweak, like in Michael's case, he had only been on, I believe, one antidepressant, maybe two. And so there was a lot of opportunities, a lot of different prescription medicines that could have been trialed in his case. So for a doctor to make that change, that's just standard, to make that change. However, there was not an outpatient psychiatric appointment set up. So that was kind of a critical spot where we thought that there was a gap in the healthcare there, because he didn't have a set date to go back or know when to get, therapy appointments. Was still kind of unclear. There was a few medications that he was still kind of unclear, because your brain is so foggy when you're in a psych unit, and you're also, Michael's struggle was lack of sleep. He was taken from a hospital in Omaha, and then transferred to another hospital at 3 in the morning, just based on the timeline of when the bed opened up. So it's just a very fragmented process. It doesn't, you already have lack of sleep on board, and then you're trying to establish your own healthcare. We were there as a means to help Michael, guide Michael through it. And of course, we thought it was like similar processes to when my mom was an inpatient hospital stay, when I was an inpatient hospital stay for our mental health illnesses. So we thought as a family that we could handle it, right? We just thought this will be okay. Michael will be okay. And I think that what I would like to get out to the public is that sense of urgency when someone comes to you and they're not well, and the certain questions and resources, very specific, that need to get out there, that need to happen, so that you can have the best success at having healthy mental illness hospitalization and discharge process.
Yeah. We have to wrap up this conversation. I want to thank you both, but to you first, Kayla, if someone is worried about a loved one right now, listening to this broadcast or podcast, what's the first thing they should do?
If you're worried about a loved one, I think the first thing that you need to do is just exactly what Lauren said. You need to ask the hard questions, and you need to ask them honestly how they're doing. It doesn't have to be anything formal. You need to just really look them in the eyes and ask them how they're doing. And then you need to ask them if they are thinking of hurting themselves. That is the biggest thing you need to do. And it can be really hard to do. We worry that that person won't want to talk to us again, but we have to do those things in love, and we have to do that. And so that is the number one. And if they do respond that, yes, they are considering harming themselves, that second step would be to call 988. If you call 988, they can connect you with the resources that you need. And to the point of, they can send out a local mobile crisis assessment team to your house, and they will be able to see how you're doing. They will be able to be on site with you, and they can transport you to a hospital or to a facility that is more capable of taking care of mental health, and they will make sure that that gets done and you get the care that you need. So that is what you should do.
Lauren, let's mention you started a podcast and survivors of suicide support group after your brother died. Tell us how people can find out more about that, perhaps listen to it.
Yeah, so the first podcast episode is available And it's actually my brother's eulogy that prompted the whole starting a podcast in the first place. But my podcast is called Let's Sit Crooked and Talk Straight, and it is available on Spotify and Apple Podcasts.
Let's Sit Crooked and Talk Straight is the name of the podcast.
Yes.
Well, I want to thank you, first and foremost, Lauren Williams, for telling us about your brother. He sounds like a wonderful individual. I'm so sorry again that you lost him. Your family lost Michael to suicide 3 years ago. Thank you for sharing that with us.
Thank you.
Kayla Mayer, thank you for joining us, Public Health Manager for Cherokee County and the leader of your county's Suicide Prevention Coalition. Thank you both for joining us.
Thanks.
It's River to River from IPR News. I'm Ben Kiefer, focusing this hour on a new report showing deaths from suicide, drugs, and alcohol falling nationally. But in Iowa and other parts of the Midwest, they're climbing. So we just heard the human story behind these numbers from Northwest Iowa. That conversation recorded last week. Now let's look at what's driving them statewide and regionally. Daniel Wheaton joins us live. He's a data reporter with the Midwest Newsroom. He's been digging into the report behind this trend. Daniel, thank you for joining us.
How's it going?
Tell us about this report, who authored it, a little bit of background here in broad brushstrokes.
Yeah, totally. So this comes from Trust for America's Health, which is this organization that advocates for improving the healthcare generally across the United States. And what they looked at is CDC data from 2024, and they looked at these so-called deaths of despair. And nationally, things are improving. Fewer Americans on the whole are dying of alcohol, drugs, and suicide. But weirdly, within the kind of region we're in, the Midwest, South Dakota is actually the worst. There are 4 states that actually saw those types of deaths increase, those states being North Dakota, South Dakota, Wyoming, Iowa, and Nebraska was flat. But overall, it seems that things are improving when it comes to drug overdoses, particularly things related to heroin. So perhaps marketing about Narcan, more knowledge about that has helped a lot. But in general, specifically within Iowa, suicides were up by 10%, as well as some overdoses. But this is relatively small numbers to keep in mind. So there were 548 suicides in Iowa in 2024. So that 10% reference is about 50 people. It's one of those things of you make these really small measurements, you make these small comparisons, you will see these big kind of increases and decreases, but it still is important to see that the whole nation is improving somewhat. So it is a mixed bag for our region, but it is a sign that some campaigns that have been going on for years are finally working.
You know, Daniel, this data, as you mentioned, from 2024. So we have to note here that we're not seeing the impact of recent federal cuts to substance use disorder and mental health treatment, right?
Yes. So all of this data is referring to 2024. So this would before all of the cuts by DOJ and other cuts made as we're kind of adjusting after the kind of boom in federal spending that happened during the COVID-19 pandemic. But they also did look at some preliminary data for 2025, and it looks like this trend is continuing. So we really won't see the effects of the cuts until several years down the road, because it takes a long time for those deaths to occur, that to be recorded, get into the data set, and for us to finally look at that. So it takes a while for us to kind of see what is happening. It's not a live dashboard. It takes a couple years.
We've used this term deaths of despair. You use it in your reporting, but the report itself does not use that phrase. Is that what's behind that term from your reporting and digging into this topic?
Yeah, I think, frankly, it's just an easy way to talk about a very difficult subject. And it connects things that are related and have very similar causes, but obviously different effects. Because, for instance, drug overdoses, those tend to occur for someone who has a substance abuse problem, while deaths related to alcohol usually occurs over a much longer time period. But when considering the root causes as to why people turn to drugs, alcohol, it's usually the same kind of problem. So it is useful for us to kind of wrap our heads around this depressing but important fact. And I think it kind of helps us kind of start the conversation in an easier way versus starting out with the harsh reality of talking about people who end up dying this way. But again, yeah, it's not within the report of Trust for America's Health, but I think it is useful for us to conceptualize these things that just share those same kind of socioeconomic causes that may cause someone to choose to use drugs, alcohol, or take their own lives.
Mm-hmm. Daniel, very quickly in 20 seconds, what will you be watching in this story? Perhaps not until next year's report.
Yeah, I just hope the pipeline of data still remains, because there's been a lot of changes with the federal government and things could get a little rocky. So I just hope we're able to do the same analysis in a couple of years.
Indeed. Daniel Wheaton, data reporter for the Midwest Newsroom. He's been digging into the report that he just described. Coming up after a short break, Dr. Alison Lynch of the University of Iowa. She sees the clinical side of this up close, from binge drinking to substance use to suicide risk. We'll talk with her after a break. It's River to River. With more River to River from IPR News, I'm Ben Kiefer. Deaths of despair, an umbrella term that's being used for suicide, drug overdose, alcohol-related death. A new report showing those numbers falling nationally, but here in Iowa, other parts of the Midwest, climbing. And so this hour, we're asking why this should be the case here in the Midwest and what can be done about it. I'm joined now live in the Iowa City studio by Dr. Alison Lynch, clinical professor of psychiatry and family and community medicine. She's also director of the Addiction Medicine Division within the Department of Psychiatry at the University of Iowa Healthcare. Dr. Lynch, welcome back to our program.
Thanks, Ben. I really appreciate being able to talk about this with you again.
And we have our phones open. You can also contact us via email if you have a relevant experience or a question. 1-866-780-9100, river to river at iowapublicradio.org. Dr. Lynch, you've been sitting here listening intently to the first part of the program. I wonder if I can get broadly some reactions that you have to the story we had at the beginning, but also how it fits into this report with its mixed findings.
Yeah, no, I really appreciate Lauren sharing her family's story about her brother, Michael. And as I was listening to her talk about some of the things just that Michael had experienced and that her family experienced, I noticed some of the things she talked about were things that we know are risk factors for suicide. So I think, this isn't, it's not, we know a lot about these deaths of despair and some of the risk factors that go into it. And I think it's just so important for us to be talking about this and for reports like the report that Daniel was talking about to be looking at this issue, because I think there's more that we can do to try to prevent these deaths, which ultimately are just deaths that occur too early in people's lives.
Yeah. Tell us a little bit more about what we're specifically seeing here in Iowa. I understand Iowa's seeing fewer drug overdoses, but more other kinds of despair, deaths, alcohol, and suicide. What do you feel is going on there? What do we know?
Well, and as Daniel mentioned, these are relatively small numbers, but we do know that in Iowa we have higher rates of binge drinking than most other states, and we know that alcohol is a risk factor for suicide. And so that, I think, is one of the issues going on. We also know that suicide and alcohol use are high in rural communities. And that's a real issue as far as access to treatment services and prevention services. And so that's something that Iowa is facing just because many of our Iowans live in rural communities. I think those are two big factors. Another factor that we haven't talked about yet is that farmers have higher rates of suicide, which is just another thing. We have a lot of farmers in Iowa, and there's a number of risk factors that farmers face, including social isolation, financial instability. And so there's just a lot of different factors that I think are playing into why Iowa is having an increase in these deaths when many other states are starting to turn the tide.
Perhaps we should also mention firearms and suicide. Most deaths of despair carried out with firearms. What do you want people who own guns or live with someone in crisis to know about that risk?
Yeah, I think it's really important for firearms to be secured, of course, and there have been a lot of efforts to try to get the word out that it's important to keep them secured. Ultimately, there's a lot while I said there's a lot we do know about kind of risk factors, there's also things we don't know as much about suicide. And one of those things is, what's going through somebody's mind right before they commit suicide. And because that's hard to study, because we can't really ask people who have experienced suicide, what was going through their mind right before. And so what we do know is that it tends to be relatively, we believe that many people kind of make the decision to take their life shortly before they actually do so. And so having access to a firearm makes it so much easier to just kind of quickly
before you can change your mind.
React. Yeah, exactly. And so having firearms stored safely, locked up, is one thing that can just sort of slow somebody down and possibly give them enough time to get help, have somebody else intervene, change their planning and their thoughts. And I think if you're on a farm, you're likely to have firearms. It ends up being a tool that many farmers use, and so I think that's another thing that leads to the increased risk for farmers.
Dr. Alison Lynch with us for the remainder of the hour, clinical professor of psychiatry at the University of Iowa Healthcare. Let's go to our phones. Andrew is with us. Thanks for waiting. Andrew in Coralville, I've noticed you've been listening to the entire show. Welcome to our program. What is your specific question or experience to share? Thank you.
I just want to share my experience with homelessness, substance use disorder, and rehab in general. So I was homeless in Alaska, was in and out of treatment, in and out of jail. I moved down here to be closer to family in Iowa. Same thing. So there was a stretch for about 3 years where I was cycling in and out of homelessness, rehab, jail. And I just wanted to say, I found that in the end, I've been to 4 different rehabs. None of them helped. I know many people who have died from it. It was actually, especially AA-based stuff. If you look at the statistics, it's a horrible success rate. What saved me and what I've got my life back under control in the past 3 years was having that family net. But I also want to point out there is no social safety net. I've worked with everyone in town. I've been into PhD at the University of Iowa Healthcare there. I value you guys. It didn't help. And in the end, what had helped me was finding a stable base. Mm-hmm. So,
Andrew, thank you for your experience, and thank you for sharing your story here. And Dr. Lynch, what do you take away from his account of what worked and what didn't?
Yeah, well, a couple of things. One is I'm glad that he raised the issue of homelessness, because that's another significant, stressor and risk factor for substance use, for mental illness, for suicide. And so we, in this conversation, we absolutely need to be talking about that, because that does affect, too many people. I think there's a lot of different things that can help people with mental health problems, with substance use problems. I don't think there's any one thing that helps everybody. And so it's really important for there to be a wide variety of options. Some people find medications really helpful. Some people find rehab programs really helpful. Some people find AA or other kinds of mutual supports helpful. Many people find that a combination of a couple of things is really helpful.
So it's really individual, it sounds like.
It is, and there needs to be kind of almost like a smorgasbord, a list of options for people. Absolutely, family support is helpful. Employment is also helpful. We think of a lot of these things as recovery capital that basically provide some support and stability for people, so that they are able to then take advantage of other, treatment options to really put that into place for them. So I really appreciate his comment. I think he raises a good point that there is not one treatment for everybody, but we need to make sure we have plenty of options.
Right, but we can do better in any situation in terms of policy. And I know you've expressed concern about our state investing a lot in incarceration, for instance, more than in investing in public health. Say more about that.
Right. Right now, but the way things are set up, many people with substance use disorders and also many people with mental illness end up in the carceral system, so either in jail or in prison. And, that's kind of how our society is currently addressing
and Andrew
this problem.
experienced that, he said.
He did. Yeah, that's another, I should have commented on that. Important that he brought that up as well. I think we underdo the public health aspect of trying to reach people and get resources to people early on before it becomes a legal issue. And it would be nice to be able to try to invest more in the public health and treatment options for people and social support kind of systems, so that we didn't have to devote our resources to the incarceration as the way to resolve this.
In a phrase, it boils down to what sounds like we're being short-sighted. And we need to invest so the long term we can bend this trend down more than it is.
Right. And we need to just move upstream a little bit.
Yeah. Okay. That's another way of seeing it. Iowa, rural state, many of our counties, we have talked a lot about on this program a mental health workforce shortage. We rank so low for psychiatrists per capita. How does that shape what's actually available to someone in crisis in this state?
Well, right now, I think it was Kayla who mentioned that if somebody has a loved one that is in acute crisis, she recommended talking with them out about it and then reaching out to 988. And that's actually been a really great development because that is available to everybody no matter where they are in the state. As far as sort of next steps and how do you get connected to a mobile crisis unit or a psychiatrist or a therapist, I think when Lauren was talking about with her brother when he left the hospital, he didn't have an appointment. It was unclear what the plan was to get him connected to a therapist. So we do definitely have a workforce shortage across the state. I think people experience wait lists or not being able to get in because the clinic's panel is full, or they have to travel a long distance to see somebody. I think telehealth has made some of that better because people can, from their own home, work with a therapist or see a psychiatrist. But there's still a lot of gaps as far as making it available to people. And I think another thing that I worry about is just how, with changes with Medicaid and insurance funding, whether people will continue to have access and have the resources to be able to access care. Yeah.
Alcohol is a big factor here in many cases. And having done this program every day, weeks, for 20 years, I really notice a difference in the way our attitudes have changed about alcohol very recently in the last 5 years. And how does that affect the way you were treating addiction and deaths of despair in the university? Alcohol is woven into a lot of our lives. We talk about rural life, fundraisers for good causes, often center on alcohol, on poker. How do we or you talk to people about that without moralizing?
Yeah, that's a great question. And I'll just add that alcohol is part of our culture across the state, whether you live in a large community or
for
in a rural
hundreds or
community.
Thousands of years.
Yes. Yeah. I think it's really important to talk with people in a non-judgmental way. Alcohol is legal. It's widely available. It's part of our culture. People get benefits. I think, Lauren described that her brother Michael, he felt more comfortable in social settings when he was drinking. And she also described him basically, it sounds like they felt like he was using alcohol as a way to address some underlying mental health issues, depression and anxiety. And so it's just really common. The majority of adults.
It sounds like that's not necessarily a bad thing when used in the right way.
Yeah, not everybody develops an alcohol use disorder. Not everybody dies of alcohol-related complications. But I think when it becomes more embedded in somebody's mental health, or when they lose control of their drinking, or it's causing them more health risks, it becomes a big problem. And I think, just to try to get people willing to talk about it and identify, what are their goals for their health, and then, how does alcohol play into that? Being able to try to talk about that in a way that people don't feel judged and feel safe talking about it.
We've had several conversations on this program about opioids and the opioid epidemic. We've seen some good news there. How does that fit into this picture, this context today, or does it?
Well, and that's one area where Iowa's death rate has gone down, right? We have fewer overdose deaths. So really the fact that Iowa's overall deaths of despair had gone up, it was related to suicides and alcohol, not so much overdose deaths. So I agree. And Daniel mentioned this, increased talking about naloxone and getting it available and getting it into the hands of people who can use it and reverse an overdose, I think has been one of the really important success stories for trying to turn the tide on overdose deaths. And I'll be clear, there's still too many people dying of overdose, but at least we are starting to see that go down rather than go up. And I think there's other things also that as Daniel mentioned, during COVID, and as we were really seeing the peak of the overdose epidemic, we're seeing more funding put into treatment and prevention and recovery services to try to help people with opioid use disorder in particular. I hope that...
Are we seeing the benefits of that investment?
I think we are. I really do. And I hope that we can, some of those there's been cuts to some of those programs. And so I hope that we don't start seeing overdoses go up again.
Yeah, we have a minute or so left. Talk about the future, what you see, Dr. Lynch, the future challenges you can see on the horizon or perhaps with us and will be with us for many years.
Well, I think we need to keep our eyes laser focused on substance use, on mental health, on suicide. And because like I said, there is a lot we know, and we just need to keep measuring things, putting funding and other resources into trying to get this way too many young people dying, to get this to turn the tide and stop having so many people die from these preventable problems.
Let's end on help for anyone listening who is worried about themselves or worried about a loved one right now. Again, what's the first thing that needs to be done right now?
If you are with somebody and you're worried about them, bring it up, talk about it. We need to be talking about this. That's how we get rid of stigma. It is okay to ask somebody how they're doing, if they and give them permission to say they're not doing well, and even ask them if they're thinking of hurting themselves, and make them understand that it's okay to say that. It's okay to ask for help.
Give them permission to do that. It's not an easy question to ask.
No, but if we don't ask, we're not going to know. And then, of course, there's the 988 emergency line for anybody acutely suicidal or having any kind of acute mental health issue. And then if you just want to get more information, the state has a website called yourlifeiowa.org that has a lot of information about treatment resources across the state.
And if you want to remain anonymous, that works too.
Yes. Yep.
It just matters. Get the help to the people who need it. Even if you don't think that the level of worry is rising to, suicide ideation, you can call or text 988. Thank you very much, Dr. Alison Lynch of the University of Iowa.
Thanks, Ben.
Today's show produced by Samantha McIntosh, technical support from Nev Kelly. Our executive producer is Catherine Perkins. I'm Ben Kiefer. Thanks for joining us.